Okay, so shall we start? Okay, so just for the sake of the time, we'll start straight away. Good evening, everyone. So again, this is myself, Mohammed Hashim. So I'll speak today about the total hip replacement, and it's one of the topics with a lot of fun. It's more of an engineering rather than orthopedics. That's why it feels more funny, and I think attracts a lot uh, of joy and intention from all the trainees. So total hip replacement is an easy operation. All what you need is just to think clearly about what you need to achieve to understand what's an ideal total hip replacement and how can you achieve that. Templating, planning, all are easy, and once you learn them, you do it very easily. So we'll go straight away. So I work at the moment in Cleveland Clinic, London. It's a private hospital, very well structured and well equipped institute, which hopefully all of you will have a chance to practice in it. So again, it's my YouTube channel and the website and the email if anyone want to approach me with any question or any clarification. So this course still have 3 lectures. So we'll speak next time about complications. Then we'll hint about shoulder replacement, then about ankle and elbow replacement. And then I will wait for your suggestions about the next course. So what shall we do for you? So think about it and keep me all comments in the chat or email me, or you all know how to contact me. Good. So if we speak about total hip replacement, you need to understand what is an ideal hip. So if we say an ideal hip, so we speak about a hip which will replicate the patient native hip. So you do a total hip replacement aiming to replicate the native hip of the patient. So you give the patient the same function, but without pain. So I will go one step backward from this and just advise every one of you, never go for a total hip replacement until your patient is really symptomatic. So if you opt to do a total hip replacement in a patient who is not symptomatic enough, you're buying a failure, because it's not a simple operation. It carries it's a major operation, is a life-changing event, and it carries a lot of risks. The technique is a bit demanding, and problems associated with it is not simple. So never go and touch your patient for a total hip replacement until your patient is really symptomatic and needs a hip. So if I decide I will do a total hip replacement for my patient, I need to think what is an ideal total hip. So to replicate the patient native hip, you need to restore the center of rotation. So center of rotation of the joint, as we all know, is just the center of concentric rings which run through the joint, and restoring the center of rotation, achieving an center of rotation of the head compared or parallel to the center of rotation of the cup in a proper center of rotation compared to the normal hip. So you, with achieving the center of rotation of the hip, you're regaining most of the function. You need to achieve a correct leg length, and if you can see, we measure the leg length either with 1 or 2 references, either through the trans-ischial line or through the trans-teardrop line. So this is the 2 references from the pelvis which you can measure the length against, either the trans-ischial line or the trans-teardrop line. And you measure it from the center of the lesser trochanter in a properly rotated film. So if you have a proper rotated film, you can measure from the center of the lesser troch to either the trans-ischial or the trans-teardrop line to ensure that you're replicating the same length as the other side. So your patient will feel the length difference, especially if it's more than 1.5 to 2 centimeters. He will start feeling that. And if I choose to go for a longer limb or a shorter limb, so we prefer to go for a shorter limb. The longer limb will end by a knee flexed. And this is what, especially if you're doing a posterior approach, you put the patient at a risk of dislocation. So the ideal is to replicate the length, so have an ideal length compared to the other side. But if you choose between lengthening and shortening, tend towards shortening rather than lengthening. You need to achieve a correct offset, and offset both horizontal and longitudinal offset. And if you keep this triangulation, if you see, like if we make a triangle between starting at the center of rotation, going transversely, and then going vertically, we're trying to restore the offset both vertical and horizontal. So this restoring the offset will give you a normal abductor tension, which will achieve proper stability and at the same time minimize the stresses over your hip and give your hip a more longevity. You need definitely to achieve a proper component position, so you don't need to have any overloading at some point of your component. You need component to have an even loading on all the parts of the component, both for the acetabulum and for the femur. So a proper component position will allow your hip to live longer and reduce the risk of overloading of or a point loading, reduce the risk of wear, reduce the risk of failure. So for an ideal total hip, you need to restore a center of rotation compared to the native hip. You need to be sure that you actively corrected the link length. You need to correct the offset both horizontal and vertical to optimize your soft tissue tension and to ensure that your hip will have a proper jump distance and movement. You need to achieve a proper component position, so a normal position between your components in compared to your patient. So more of a what's called like a kinematic knee. We can do a kinematic hip when you get and achieve when you achieve a proper component positioning compared to the patient native. So when we go to the acetabular component, so our hip is acetabular component, femoral component, and a bearing surface. And every component has fixation, and every component first deposition and fixation. When we speak about the acetabular component, so we guided by guidelines, which is ODEP, and we'll go in a minute to explain you what is ODEP. But when you look to an acetabular component, you look for a successful component. And successful component from the NGR, from the National Joint Registry, is these components in front of you. If you are doing a cemented hip, so it's a contemporary flanked cemented cup. If you're doing an uncemented, which is a more commoner, you use a Trident uncemented cup. Both comes from Stryker and both achieve a very good longevity and a very good results in the NGR. So with excellent survival, very good revision rates or outcomes, you can safely and medical legally achieve what you aim for from your total hip by using a successful component like that. So 13A plus is now become 15A plus because this component is in the market for the last 15 years, and I will get you through the ODEP rating in a minute, explaining you what does it mean 13A plus or 13A star. So 13A star means this component is in the market for 13 years with a very low revision rate, and this is evidenced by a good or high quality evidence. Regarding the femoral component, you have a lot of options. So the most successful, again, the most successful stem in the NGR on the National Joint Registry is the Exeter stem. Is again 15A plus now, not 13. So it's achieving 15 years in the market with a very good longevity and low revision rate. And this is evidenced not only statistically, but also supported by high quality evidence. The good thing about the Exeter system is a very versatile system. So you have a lot of options in the stem. You have a lot of options of the offset. You have a lot of options in the adjustment or the neck. You have a lot of options in the head. So it's very versatile in your hand. You can adapt it to your patient and adapt it to the surgical situation when you open the patient. You can achieve all the primary aims of total hip replacement using the Exeter stem. So you can achieve the center of rotation. You have versatility to adjust the offset, both horizontal and vertical, and it's very easy to do. Has a good initial fixation and long-term survival according to the NGR. And when you ask in the exam, that your answer will be, I'm trained on Exeter techniques and familiar with the instrumentation, because that's actually that's the reality. So the reality is you use what you are trained on, you use what's available, and Exeter is one of the most available implants in UK. It's successful implant, it's evidence-based with the NGR, and it is what is every trainee in this country is trained on. So what's ODEP? So we said 13A plus, 15A plus. We need to understand what's ODEP. How can we justify the use of a component, either acetabular or a femoral component? So ODEP is a way to justify this. This was invented by the nice guidelines long time ago, the National Center of Excellence. So it's basically rating the implant pre-entry before they put it on the ODEP rating at 3 years, 5 years, 7 years, 10 years, 13 years, and now 15. And by spring 2026 will be 17 years. So the highest at the moment is 15 because this ODEP system is in actions for 15 years now. So the highest rating is 15A plus, which means the implant is in the market for 15 years. And A means this implant has a strong evidence it is a successful implant or not. So A means this implant has a strong evidence it's successful with low revision rate. B means it's reasonable. C means it's weak. And the plus means that the revision rate of this implant is less than 5% in the last 10 years. So when you say ODIP, you say you have an evidence on the longevity or the exposure of this implant to the market. You have an evidence on the low revision rate. You have this supported by a good and high quality evidence. The requirement for you to put an implant on the ODEP rating that you have more than 500 implant already implanted in a patient. You need data from more than 3 centers and surgeons. You need to be sure that your revision rate is less than 5% in 10 years to say it is an A or a high survivor or a long survivor implant. And you need at least not less than 20% has been lost in the follow-up to be sure that your data is significant. So ODEP rating is the way is basically the ID of the implant. So you need to use an implant with a good ID, which means a good ODEP rating, which says that this implant has a long survival, has lower revision, and this implant is this is supported by a strong evidence. Okay, so beyond the compliance is just not only for us to understand the ID of the implant, but this is allow us to this is supports a safe and stepwise introduction for new and modified implant. If I choose tomorrow to go for an implant, so I've been introduced a new implant by a company. What I will be doing, I will be asking about the ODEP rating of this implant to ensure that the use of this implant will be safe, and this is allow me to start using this implant safely and in a stepwise. It's a way of introducing a new implant to the market, so the industry cannot put an implant on the market unless it has a proper ODEP rating and we sure it is safe to do. So this data definitely shared with the clinicians as the end users, and with the manufacturer and with independent assessor to ensure that the whole process is governed properly and it's easy to monitor and catch any early problems with any implant. So ODEP allows us to catch any failing implant very early and try to avoid this implant. So what's the evidence on the use of these two implants, either the acetabular component from Stryker or the Exeter component, Exeter femoral component from Stryker? The evidence is limitless. It's a lot of evidence, a lot of proper studies, a lot of proper trials, which all evidence is that the survivorship of the Exeter stem and the Trident cup is 90% plus. The very low revision rate, less than 2.2% at 10 years. All these are proper reviews, and there is a lot of evidence beyond that which is supporting the use of both implant, both the acetabular component and the femoral component. So if we agree what component will we use, so we agreed we need an ideal total hip. We'll achieve that by achieving a proper and a replication of center of rotation or restoration of center of rotation to the native side. We'll correct the lens, we'll achieve a proper offset, and we achieve a proper component position. Then we choose the component and we use the ODEP rating to identify what is the proper component to use in a acetabular side and on femoral side. Now, how will we fix this implant in place? So to fix this implant place, we have two ways of fixation, either cemented fixation or cementless fixation or uncemented fixation. So both options are valid. All the evidence supporting that both of them in a normal situation is successful. There is no a preference for one over the other, but you have the choice to do that based on a lot of factors, based on what you trained on, based on what's the patient factor, how is the bone quality, what implant are you using or you are familiar to use, because every implant has a way of fixation. What if I opt to do a cemented fixation? So cemented fixation basically is ideal for an elder patient. So it's about the longevity. It's more of a non-biological fixation because you put a cement interface between the implant and the bone. It's a bit difficult in revision. So if you go for a cemented fixation and you want to revise this implant, getting this implant out, you need to clear the canal from the cement. So it's a bit difficult revision. risk of cementation syndrome or cement implantation syndrome, which is a risk during implanting or putting the cement in. It's the risk of getting a cardiopulmonary problem while you're putting your cement in. So there is a risk of what we call cement implantation syndrome. But still, it's very viable option. It's one of the most common ways of fixation used at the moment. It's suitable for all types of bone, especially osteoporotic bone. It achieves immediate stability. You don't need to wait for the implant to get fixed inside the femur. But in 24 to 48 hours, your cement is completely settled, and you're fine to use you're fine with the stability of your hip. On the other side, the uncemented fixation is more ideal for a younger patient who will need the hip for a longer time. It's easier to revise because you don't need to clean anything in the canal. Once you get your stem out of the canal is clean and you can revise your stem. Definitely, there is no risk of cementation or cement implantation syndrome because there is no cement. But on the other side, it needs a bone with a good biology to heal. So either with on-growth or in-growth, as I will explain in a minute, you need a proper bone quality, a good biology of the bone to get the stem fixed in place. And delayed weight bearing is not there anymore. We weight bear all of them day one or day zero even. But theoretically, with cementing, you are more safe to mobilize your patient earlier than uncemented because from cementing side, you already fixed your implant and you're sure about the stability. But this is not a case anymore. So all of them are weight bearing day zero. All of them doesn't have a delayed weight bearing. The delayed weight bearing is just theoretical. So how I'll decide? So I'm in front of the patient. I'm planning my total hip replacement. Will I go for a cemented or uncemented fixation? I need to decide. So decision pyramid is very simple. So you need to look into the bone quality of the patient. You need to look into the patient characteristic or the patient ID, and you need after that to decide about your fixation. So if patient is young, needs the hip for a long time, bone quality is good. So I will opt more for an uncemented fixation because, as I told you, this is a more of a biological fixation. Fixation will be very strong with an ingrowth or ongrowth, and it's easy to revise and all the advantages we spoke about. If the patient is elder and the bone quality is not the greatest, I'm worried about intraoperative or iatrogenic periprosthetic fracture. This is the way I will go, the time I will go with cemented fixation. So patient characteristic or patient ID, then stem ID is what was decided what we will go with the fixation wise. So if we speak about the uncemented fixation, there is two biological ways for uncemented fixation to achieve the stability. So you put an unfixed implant. This unfixed implant, either it will be rough surface or will be a porous surface. So both of them will allow a type of growth from the bone over the stem or implant, and this will achieve the fixation of the implant or the stability. The ingrowth and ongrowth is basically ingrowth. There is pores inside the implant or the coating above it, which allow the bone to grow inside these pores. Bone ongrowth is basically a rough surface which allows the bone to grow over the implant from outside. Both of them, each one of them has own characteristics, benefits, and risks. It's not something you control by type of the implant. So ingrowth, basically, to understand it, so there is pores, and the pores either in the implant itself or the coating above it, especially if this coating can stimulate bone healing like hydroxyapatite coating, which allow the bone to just grow inside the pores and get fixing the implant to bone. Ongrowth is just a rough surface which is allow the bone to grow on top of it. To achieve a bone ingrowth, you have a lot in the technique to achieve to get the bone ingrowth to happen. So, how much space do you see? It has to be a press-fitting implant. You need a proper size of the pore, so less than 550 micron. You need minimal micro motion between the bone and the surface of the bone and the surface of implant to allow the ingrowth to happen. The ongrowth on the other side is more forgiving than the ingrowth. So all what you need is a proper brace fitting and apposition of the rough surface of the implant in on front of the bone, so the bone grow on it like a great glass tit. So ingrowth, pores in the bone or in the cover and the coating or the cover of the implant, which allow the bone to grow in. needs a lot of biological environment to allow this to happen. So size of the pores, distance between them, distance between the implant and the bone, amount of micro motion between the implant and the bone to allow the ingrowth to happen. On-growth, basically rough surface which allow the bone to grow on top of it. If we come to the cemented fixation, so the cemented fixation, there is two principles for the cemented fixation to happen. Again, same concept. So unfixed hip goes inside within a cement. This cement is not grout. Is basically it's not something which glow the stem in. It's more of a grout, just filling the space and allowing for what we explain now in a minute, either composite beam or a taper slab to happen. So basically, the composite beam, which is happens with unfinished stem, which goes inside the cement. It's a concept of a tube inside the tube. So bone is a tube, has a cement inside, making another tube, and just your stem is sitting inside the two tubes like a full composite. Doesn't allow for any substance. I'm sorry, subsidence. So a composite beam idea like happens with a Shanley hip or a Shanley implant, as I will show you in a minute. Basically, it's a rough surface, goes inside a cement, which is a first tube, and the cement and the implant goes inside the bone, which is another tube. And all of this is like a one composite beam, doesn't allow any subsidence anymore, and this is achieve stability from minute one. The taper slip is a stem which has a taper, has a differential diameter in the three planes. It could be uniplanar, could be biplanar, could be triplanar, could be a double taper, could be a triple taper. So taper means, as you can see here, there is a differential diameter between the proximal and the distal end of the implant. So this could be on one plane, which is will be one taper, could be in two plane, which is double taper, could be in three planes, which is triple taper. Plane, I mean vertical, which is either sagittal, coronal, or axial. So the taper slip, basically, it goes with the idea of hyposteresis. So all you need is for the taper slip is you put your implant. You don't aim for this implant to be sticking into like a composite, but allowing this implant should be very polished, very smooth to allow this implant to go for a controlled subsidence. So we aim that our implant to control the subside inside the cement, and when it starts to subside with the weight bearing, it applies the hope stresses over the tube around it. So composite beam, I need a full composite from the start, one structure, which is stem inside two tubes, the cement tube, then the bone tube. On the other side, the taper slip basically is a smooth implant, which is a polished implant. We allow it to subside, controlledly subside inside the cement, just to apply hope stresses with the weight bearing. And both options are a very good way of fixation. Both options show they are valid options. So how did the femoral stem develop? So starting from Shanley in 1960, when he started to invent in the idea of total hip replacement, he went through a lot of stages. Unfortunately, it's a lot of wrong information about Shanley. So Shanley started with using a taper slip. Then when he started to encounter a lot of failures, he moved to use a composite beam. And the commonest that Charlie is using a composite beam because this is its commonest stem, but this stem wasn't his early stem. He passed by many stages before he reached to this final stem design. Same for the head. When he started using a large head, then he started to go from large head to smaller head to apply his principle of low friction arthroplasty, and I will explain this in a minute. And he was using a cemented cup, so he didn't realize that a lot of failures is coming from this principle itself. So using a large head over a cemented cup, you're buying a failure. But we all owe him a lot as the godfather of all the arthroplasty, hip arthroplasty. So Shanley, when he started, he used the available material at that moment was a stainless steel. So he used a stainless steel. As you can see, the stem is monoblock, so you don't have any versatility in it. So you cannot change this relation. You have a fixed hip to the implant. There is no adjustment. You cannot play with the offset. So it's very, very low versatile. As you can see, it's not polished, so it's not tapered. So the implant goes with the composite beam idea. So you insert your implant nicely fitted inside your cement tube, and cement tube is inside the bone tube, and you need this to act as a composite without any subsidence. He felt that if he put a rough surface, so why he doesn't polish the implant? He think that with rough surface, which is absolutely correct, with the rough surface, the implant start to stick inside the cement, and this is achieves more the composite beam idea. As you can see, he have here a bit of shoulder, and this shoulder was mainly to reduce the subsidence and to add some load to the proximal femur to avoid the stress shielding. He tried to use it as a one rigid unit, the same as a composite beam idea, and he think that stability depends on a strong cement bone implant bond. So he tried to make a one bond between the implant, cement, and bone, which is a composite beam. This Shanley, as you can see, so any subsidence, he felt that any subsidence inside this composite beam will end by loosening, and this is was true. And the composite beam achieved a very good stability for a long time. We see Shanley stems up to today after 50 years, and they are very long life, and they are very good way of fixation. So the idea is very valid. So his problem is shear forces goes through the cement, and was the main problem he's encountering that the cement is not good in shear. The cement is good in compression. So with the cement having a shear forces, this increase the risk of cement fracture. When you can see, so his idea of, if we go through the stem itself, so monoblock, small head, and I'll explain you every part why he went for every part. So small head, he invented the idea of low friction arthroplasty, and if you come to what Shanley achieved, he achieved a lot, but he didn't write except this concept, the low friction arthroplasty concept or book. And his idea is because he was using a cemented cup, when you use a small head, so the movement, the shear movement goes with the movement of the joint. From a small head is less shear on the cement bone interface that are behind the cup. So he thought that with a small head, he achieving low friction, and this low friction means less stresses, less shear stresses moved from the moving part to the cement bone interface, and this achieved for him a long life implant or reduce the loosening. So his idea from the head was to achieve a low friction arthroplasty. So a small head moving inside this cup, so means less friction, and the less friction between the two surfaces means less shear forces shared across the bone cement interface in the cup side, and this means the cup will live longer without any failures. So he has here a short neck, then he has here a cooler. He is the first one to introduce the cooler idea, and the cooler here for Shanley was to stop subsidence and doesn't allow the system to subside in. Nowadays, we know that this cooler is not only against subsidence, but also against any periprosthetic fracture. So it controls the rotation of the stem. It reduces the risk of periprosthetic fracture because it loads the medial calcar, and the same idea as Shanley aimed for, it reduces the subsidence of the implant. Then, as I told you, the shoulder, and he thought about the shoulder again is a point to reduce the subsidence of the implant, and at the same time to load the proximal femur and avoid the stress shielding. Then, as you can see, is a rough surface which goes inside the cement as we agreed before, to makes a very very good bond between the bone, the stem cement, and the bone. So that's the main implant from Shanley. The implant we're using nowadays, which is the Exeter implant, which we spoke about before. So this was invented in 1970s, has moved through a lot of stages of development and improvement. This is the implant we have nowadays, which is double tapered and is very smooth, very, very polished. So to understand it, so the head is the whole thing is modular. So you have a head, you have an adjustment in the neck, you have a trunnion, and you have a shoulder, then you neck, shoulder, then you have the implant, the tip, and the tip attached to a centralizer. And I have a photo for it. Yes. So if you look here, if we go through the Exeter again, so we understand that the Exeter fixed in the cement and bone by the idea of taper slip. Means when I put this implant inside the cement again, it's tapered, so means the distal end is smaller than the proximal end. So every time you weight bear on it, every time it's loaded what will happen? Will happen a controlled subsidence of the stem inside the cement. This applies the Hope stresses on the cement tube and the bone tube, and this is the way this implant is getting fixed. It has a trunnion, and this trunnion called 12/14, 12 over 14. So this size is like a conical structure. This is 12 and this is 14, and this is works well for the locking of the adjustment of the neck. So you put your adjustment of the neck over the trunnion, and it locks inside by the 12 to 14 differential diameter. The adjustment allows you to improve the offset. So when you end by putting your implant in and you feel that your soft tissue tension is not the greatest, this modular adjustment or neck allow you to add up to 4 mm plus or minus, up to 8 mm plus or minus according to what you are using. So it allows you to improve, to increase the offset or reduce the offset if you already committed to the implant or committed to the fixation of the stem. Then you have the neck and the shoulder. And again, the shoulder is mainly for loading the proximal femur and allowing for less stress shielding. Then tapered in two planes in this sagittal plane. And if you lock from the coronal plane, it will be tapered again. And this double tapered allow for the idea of taper slip. So if you go back, as you can see, is aim for controlled subsidence, which is quantified by 1.5 mm in the first 12 months. So if you finish your implant at this level in 12 months, and if you go and examine your implant have been subsiding by 1.5 mm inside the cement, and this is applies the Hope stresses and makes the idea of the taper slip works. The centralizers allow basically for even distribution of the cement around the tip, doesn't allow the tip to be resting on one of the cortices, and it allows proper insertion of the implant going all the way down. So with a proper cementing, if you have a centralizer, especially if your stem is above 35.5, so the centralizer allows for central position in the cement, even distribution of cement around the centralizer, and avoid that the stem is resting on one of the cortices. So yeah, so all this we explained. So if we go to compare both of them, easy way, that's small block, that's modular, this is shape closed because it aimed to achieve a composite beam. This is a double tapered. This surface is rough to apply the composite beam idea. This is highly polished to allow controlled subsidence and apply the taper slip idea. Both, as I told you, so this is modular head, this is fixed head. This is encounters failures as a cement fracture or proximal osteolysis, but this is rarely to have a septic loosening. Mostly will have either a periprosthetic fracture or infection. If exam wise, so if he asks you in the exam, describe this stem for me, that's more of an exam mind. You need to comment on these 7 points. So don't say, oh, that's the Shanley stem and that's it. No, he asking you to get from you that you understand the mechanics behind every design. So the stem in front of you has a design. This design, every part of the design, as I explained to you, carries a meaning. Why there is a trunnion, why there is a neck, why there is a shoulder, why there is it's double tapered or triple tapered or single tapered, why there is why it's polished, why there is a centralizer. So you have to structure your answer. Get this slide a screenshot or keep it with you if you're going to for an exam, because to properly describe a stem, you need to go through these 7 points. So what the shape of the stem is straight, it's curved, it has a shoulder, it doesn't have a shoulder, it's monoblock, it's modular. Then you need to go to the tip. How is the tip? It's blunt, it's tapered. How is the surface finish? Is it smooth, polished, or rough and matte? Does this implant modular allow for adjustment offset or version or head side, or just a monoblock? Is it collared or collarless? And how is the neck geometry? You have to explain what is trunnion, and you understand why this trunnion is there, because the trunnion will have a big problem with the complication in the form of trunnionitis, and we'll explain this. What about the offset? Is the offset standard, or it can be changed to a high offset, low offset, varus neck, valgus neck, or it's a modular offset like the Exeter? So you have to comment on the 7 points if you are in an exam and you're being questioned about the stem. So we bought a stem in, we bought a cup in, and now we're speaking about the bearing service. So the connection between the two fixed components, we need bearing, we need the joint moving. So you have the options to your bearing to be hard on hard, so either metal on metal or ceramic on ceramic, or to be soft on soft, which is very rare nowadays, or to be hard on soft, which is the commonest use. which like metal on polyethylene or ceramic on polyethylene. So the options for bearing either to be hard on hard, which is metal on metal and ceramic on ceramic, soft on soft, which is poly on poly, which is very rare nowadays, or to have hard on soft, which is the commonest, like metal on poly or ceramic on poly. So every one of them has an indication, and you have again to tailor your decision based on your patient, based on in the patient activity, based on the patient soft tissue, patient in the bone, patient bone quality, and what's your patient expecting from the hip. So if I have a young patient, very active, sporty man who is doing a lot of sports, he aiming from this hip to regain the function, which is high impact function, I will go to hard on hard. I will go to metal on metal. I will go to like something like resurfacing. If I have an old lady, which is low demand, all what she needs is a long life hip for the rest of her life with less revisions, I will be using a metal on poly, and I will be choosing the head size based on that. I will be choosing the type of fixation based on that. I'll be tailoring everything for that. If I have patient who is active and not that sporty, but he active and wants to go and want a less wear, long life implant, giving a good function, I may think about doing either ceramic on poly or ceramic on ceramic even. And every one of them has its pros and cons. So every option from the four options in front of you has a pros and cons. And you choose them based on type of patient, type of the bone, type of the quality of activity of the patient, and definitely your experience or surgical preferences. Every one of them has pros and cons. We'll explain every one of them in a bit of details, but you need to understand again, general concept. Your bearing could be hard on hard, metal on metal, poly on poly, or ceramic on ceramic, soft on soft, which is rare nowadays, and then hard on soft, either metal on poly or ceramic on poly. Head size is very important. You need to understand how we choose a head size. Shall we go with what Shanley spoke about, the low friction arthroplasty, and always use a small head? Or shall we go for a large head, which is the new concept? And what is the benefits and risks of everyone? So a large head allows you for a better range of motion, because basically the arc of motion of the large head is bigger, as you can see from this picture. And at the same, this is what called the jump distance. So this distance from the head, the neck impinging on one end to the head impinging on another end depends on the diameter of the head. So if you have a large head, this jump distance is very big, so the risk of dislocation is less. But on the other side, with a large head, though it gives you a better range of motion because the arc is bigger, it gives you a more stability because the risk of dislocation from impinging or the jump distance is bigger. But on the other side, you have to use a smaller pulley. And when you use a smaller pulley or a smaller plastic, the risk of this plastic to fail and wear is higher, and the longevity of the implant is less. At the same time, because the large head does a volumetric wear, so the risk of wear is high, the risk of osteolysis and failure is high, the risk of edge loading is high. So you need to think about everything as a pros and cons. There is no absolute positive, no absolute negative. So large head has its own benefits, but its own risks at the same time. So with a large head, again, the benefits are, or the pros are, increased stability because there is a big jump distance. So for the head to start, the neck to start to impinge on one of the edges and dislocate from this side to that side, this distance is big in the large head because the diameter is bigger. The arc of movement is bigger, so the range of motion of the patient will be better than a smaller head. But on the other side, we have to use a smaller poly, which means longevity of my implant will be short. And we have to think about the volumetric wear, which is a higher risk of wear and risk of osteolysis. And we have to think about the edge loading. So if you stop at this point, you are here, you need to think what my patient needs. Am I in front of a young patient who needs a range of motion, who needs a longer life hip, he needs a less risk of dislocation with extreme range of motion? I'm going toward a large hip. Is my patient is an old patient, which is just need a simple range of motion, doesn't need to go for extreme range of motion, all aiming for having this implant with a very low revision rate and a very long life implant. It doesn't need, like he's in his 70s or 80s and he doesn't want to go to revision in his life. So I think about a smaller head so I can achieve larger poly, I can achieve more longevity, less wear, so risk is less. And I'm not worried about the risk of instability or dislocation because the patient is low demand. So if you think about a patient who needs more range of motion, so bigger arc, bigger jump distance, so big range of motion with less risk of dislocation, but you have to understand that you will pay a high volumetric wear and risk of osteolysis or loosening, a smaller body, which is shorter lifespan, then go for large head. If you think that your patient needs less range of motion on behalf of a a longer life of the implant and less wear, think about a smaller head. So every one of them, as you can see, has a pros and cons, and it's your decision depending on your patient activity wise, what the patient expecting from the hip. Is he expecting from the hip long life hip with less complication, less risk of revision, even with a smaller or less range of motion and a smaller risk of increasing dislocation? Go for a smaller head. If my patient is very active, needs a bigger range of motion, needs a more stability on extreme range of motion, but he can understand that this is makes the longevity of the implant less and the risk of edge loading high and the risk of wear and loosening high, go for a large head. Now, the templating. And as we all know that failure to plan is a plan to failure. So it's more of a plan more than the technique. If you plan properly, the risk of you failing the technique is very low. If you go haphazardly without a plan, you need, firstly, a lot of experience. You need a lot of luck to get a successful operation. So if you plan the operation properly, the risk you are going, it will be going wrong way is very low and other way around. So even you are a just junior surgeon starting to do your arthroplasty job, go and template every patient. So you are at a lower risk of getting this operation wrong. If you are an experienced surgeon, it's again, you need templating to get it right first time. Without templating, you're putting a lot or you're depending a lot on your experience, on your luck to get this operation right. So templating, the idea of templating is you try, as we agreed, to achieve an ideal total hip. An ideal total hip, again, to achieve or restore a center of rotation, restore length, restore offset, and soft tissue tension, and get a proper alignment or position of the component. Our idea from the templating is to try to expect the sizes, the position, and the biomechanics, where I will put, what component will I put, what is the size of the component, and what is the position or inclination of the component I'll be putting. The importance is it gives me a clear idea what I'm going to do. It minimize and make it more objective, minimize the subjectivity in choosing either using my eyeballing or finger pulling. I'm more toward templating and use proper sizes, whatever the way of templating you do. You don't need to have a fancy digital application like TraumaCAD or whatever. You can do this on a paperwork. Professor Abdelkarim has a very good lecture about templating on a paperwork, I think on the Qasr Laini YouTube channel. And it's a very, very good lecture on how to do it on a paperwork. In UK, you have the option or the facility of a TraumaCAD or whatever templating system you have. That's fine. But at the end of the day, the main concept is to have a proper templating, a proper operative plan. So you go there clearly minded about what you need to put. And you know that the variation within a size up or down is there, but you're not far away. And if you're far away, you need straight away to think about there is a problem, there is a complication. If I templated my cup to say 46, then I went in and I found it 60. So I have to think straight away that I've broken the acetabulum. So the posterior wall has gone. So I'm not going there to see, oh, I have to put a 46. It's not that, this is not the aim of the template. Aim of template is to give you an understanding what you're going to achieve, what you're going to have inside, and then you understand where are you. When you feel like you are not in the place you're waiting to be in, you understand that there is a problem and you have to think what shall I do with it. Is it accurate? Yes. We've done a recent study and the accuracy is 85% plus. And between one size up or one size down, you can achieve what you templated. So the templating is not imaginary, it's an actual objective way of planning your surgery. So to have a templating, you have to have a proper X-ray. There is no point to template on a improper X-ray because basically the answer will be wrong. If you ask the wrong question, don't wait for the answer to be right. Answer will be wrong. So you need to have a proper radiograph to understand this. It have to have all the patient information. It have to be, the landmarks have to be there. The leg length discrepancy has to be clear. And then when you start to template, you have to think about templating acetabulum first, so you can restore the center of rotation of the acetabulum, then start to mimic the stem on it and try to get the center of rotation of the head of the stem or the tranion uh, uh, co-opted over the head at the center of rotation, or following the center of rotation of the acetabulum, so for you to achieve a properly centrally rotated implant. So if we think about the landmarks, we look into the X-ray if we have an ideal X-ray. So your ideal X-ray needs to be the simple things, which is centralized, proper exposure. Patient is exposed. You need to have the whole pelvis and the proximal femori, at least 30 to 40% of the femur, of the proximal femur, for you to be able to plan. You have to involve the lower lumbar spine to understand if there is a lumbar lordosis or lumbar scoliosis, because when you lose the spinopelvic mobility, like in this case, so that's severely spondylotic spine. So you lost this movement, the spinopelvic movement, and this is put a lot of risk on your hip. So when you're putting a hip in a normal spine, you still have a spinopelvic movement. So your hip can be covered with the spinopelvic movement. If there is no spinopelvic movement and the spine is very stiff with an with spondylosis, you know that this movement is not there anymore, and this is will change your technique. You need to get a more cover, anterior and posterior cover, whatever the approach you are going through, because your hip is at risk because there is no spinopelvic movement. You have to have the femurs in internal rotation, and we all know that the anti-verge is about 10 to 15 degrees. So we need to get the foot in internal rotation 10 to 15 degrees to get the neck in the plane of the cassette, so you can see the neck completely in a proper lens. If you end by externally rotated film or internally rotated film, they will change the length of your neck, and this will give you a wrong offset when you template. You need to be sure, you need to see clearly the lines, the jotted lines on the acetabulum. You need to see the LUSK line, because this is where you will plan your acetabular component on. You need to see as much as possible from anterior and posterior wall, the source seal or the roof of the acetabulum. And this is all has to be clear for you to do a proper templating. You need definitely, because as we agreed from the start, we will judge our lens on either the trans-ischial or the trans-teardrop. So I definitely need to see the two ischial tuberosities and the two teardrops properly. Sometimes it's not that easy, because sometimes there is an osteophyte over the ischial tuberosity, and more common are central osteophytes in the teardrop, which disturb the teardrop, so you cannot judge on it. So you have to try to use the two options, and experience comes here. So if there is an osteophyte, teardrop is not that clear, ischial tuberosity is not that clear, this is when you have to employ your experience to get a proper reference for your lens. Acetabular landmarks, which is very important to us. So firstly, the LUSK line, which will be our median end, so which limits for us the floor of the acetabulum. We shouldn't go more than this when we're putting our acetabular component. We need to see what's called the source seal or the acetabular roof, because we need to be sure that our component will be covered. So up to 20 to 30% of uncoverage of the component is acceptable, but no more than this. We need definitely to see the teardrop and ensure there's no osteophyte, because if there is an osteophyte, means this osteophyte is in the floor of the acetabulum, and I need to be careful while I'm doing that. If my acetabular is retroverted or antiverted, I need to be sure from a frog lateral view, because this will change my mind. If I have a retroverted acetabulum, I know that I need to antivert my cup more. If I have an antiverted acetabulum, I need to know I need to know that I don't need to antivert a lot, because the acetabulum itself is actually inherently antiverted. You need to see the femur, so you need to see, as I told you, if properly rotated. If you see that is internally rotated, that's externally rotated. If you need to see a proper rotation of the film, you need to see the lesser troch, because you will judge your lens on that. You need to see all the fossae. You need to see the neck in a normal lens. You need to see the full head. You need to see the trochanter. Sorry. Again, before we start templating, we have to keep in mind what we're aiming for. You need to know to go to some place, you need to have the map. You need to know where are you going. So we're going to replicate the center of rotation. This is the normal center of rotation of the native hip. We need to replicate the center of rotation of our implant. Firstly, the acetabular component, and get the femoral component to follow it. So this is the center of rotation we aim for, which is comparable to the center of rotation of the native hip. This is the ilioischial line, which be our medial border or medial limit for medializing the component. As we understand from the basic science, we're trying to minimize the stresses over or the joint reaction forces over the hip. So we aim to medialize as much as we can from the component, from the acetabular component, but not beyond the ilioischial line. Otherwise, you'll be going inside the pelvis. You need to measure your length and try to replicate the length on the other side. So, and we said there is two reference point, either transischial line or trans-teardrop line, and you need your center of the lesser troch comparable on both sides, either to the both one or both of the reference points. You need to be sure that your implant is sitting nicely, especially if you're using an uncemented implant like this one. You need to be sure that it's sitting nicely inside the medulla. It's not resting in varus or valgus, because if it is in varus, the tip of the stem will be resting on the lateral cortex, which is very risky to have an intraoperative or post-operative periprosthetic fracture. And more dangerous is to have it in a varus, which means the implant will be resting on the medial. The tip of the implant will be resting in the medial cortex. So imagine when you have your implant in varus or valgus, when the patient start to load, if it is in valgus, you're putting all the load. It's much better than being in varus, but you're putting all the load through the lateral cortex. If in varus, you're putting all the load through the medial cortex, and you're buying a failure. You're trying to get this implant to fail by putting the stem wrongly in varus or valgus. You need to have a proper offset, so trying to replicate the distance between the longitudinal axis of the femur and the center of rotation. So if you measure this distance in a perpendicular distance, this is the offset we aim for. And if you don't replicate this offset properly, if this implant has a smaller offset or short offset, or if you're using a modular implant using a shorter neck, the short offset means less soft tissue tension and more risk of dislocation. If you make it a big offset, yes, you increase the tension, and this increase the tension to a degree is okay, but more excessively increase the tension or the offset will end by more stresses, more stress inside the hip, and will end by a prominence of the GT, especially in ladies or females. They feel the GT very badly, and they come with complaining of trochanteric bursitis and trochanteric pain if you opt to have a larger offset than the normal. So you need an ideal center of rotation, you need an ideal length, you need an ideal offset. But if you go away from the ideal, so shorter better than longer for the length, bigger offset better than lesser offset if you're not getting the ideal, and a bigger offset is bigger offset better than short offset. Valgus is better than varus. So our aim is ideal center of rotation, ideal leg length compared to other side, ideal offset, ideal position or position of a component. If it will not be ideal for any anatomical reason, for any problem, for any reason, I opt to be on a shorter side rather than on a longer side, on a bigger offset side rather than a lesser offset side, on a valgus position of the stem rather than a varus position of the stem. So when we start to template, you start templating your acetabulum. So as you can see, that you choose either if you have a measurement pole here, so you have a calibration. If your film is calibrated, the system will identify the calibration. Imagine I will speak about the paperwork. So because not every hospital have the same system. So if your picture is calibrated, you know how much magnification is in the picture. You can truly template the picture. If you have the caliber, the system, if you're using a system, this is the caliber, this is the measurement ball. The system will be choosing the implant for you automatically, like a suggestion. So as you can see, he put it for me, this cup size says 44, 46, 48, and he put it on the ilioischial line as the medial border, and he inclined it like 40 degrees, and he kept only like 10% of it uncovered, which is an ideal position for my cup. So when you put your cup, you need your cup to be inclined about 40 degrees. You need your cup to be medialized as much as possible up to the ilioischial line. You need your cup to replicate the center of rotation as we planned from before. And you need your cup, if we're looking into the version wise, to be a bit antiverted. Once you have the cup in place, so you start planning the stem. So you need the stem to fill the canal. If you're using a cemented this and accolade stem, if you're using like something like accolade, you need to put the stem breastfitting into the canal to achieve on-gross or in-gross according to the type of the stem. Or even if it's a cemented, you need your stem to be centered in the canal and filling as much possible of the canal. We all know about the French paradox, which we all days, Shanley days, he expected that more cement around the stems means more stability. But nowadays we know no, there is a French paradox means all what we need is to get the principle rightly, not by amount of the stem. So you need your stem to be centralized into the canal. You need the shoulder to be this shoulder to be under the greater trochanter to get a proper fixation and to load the whole proximal femur. Then you need your offset to be proper. You need to get this tranion center of rotation on the center of rotation, I'm sorry, on the center of rotation of the cup, and both of them to replicate the center of rotation of the native hip. So central stem in the canal, no varus, no valgus. Try to get the stem nicely filling the canal, just the shoulder under the greater trochanter, and you need to restore the offset up to getting your center of rotation of the tranion on the center of rotation of the cup. What if I end by center of rotation of the stem of the tranion below the center of rotation of the cup? Basically, what's fixed? The cup is fixed. So you will put your cup, you fix your cup. So this center of rotation is fixed. So if you put in your templating the center of rotation below it, means you are shortening, because when you come to the actual situation with weight bearing, this will come back to this, means you will shorten. And other way around, if I end by the center of rotation of the tranion above the center of rotation of the cup, in the real situation, the stem will go down and you lengthening. If you keep the center of rotation more lateral to the center of rotation of the tranium, more lateral to the center of rotation of the cup, means you are reducing the offset. If you go in the other way, it means you improve increasing the offset. So ideally you need ideally positioned a stabler cup and the ideally positioned stem, and both center of rotation just coapting on each other with a proper offset. You can restore the offset as we explained. There is a lot of options. It's different from using cemented to uncemented stem. The uncemented stem have a lot of modular necks, which you can change the proximal part into a high offset, into a varus, a lot of options like KA, KH, different options according to the different implant. You have this option in the cemented side with modulation or the neck adjustment. Tips: as much as possible, try to go for a mid-range size. As I told you, we accept one size up or one size down. That's fine. That's not a problem. The plan your cut, as we all agree that you will be cutting the neck about a 1 centimeter or 1.5 centimeter from the laser truck. So plan your cut and ensure that your implant is sitting nicely and all covered inside the medulla. And this will give you an idea where should you stop with your implant, either from the marking here, or if you measure the distance from the tip of the greater trochanter to where your stem should be. So intraoperative, you will see this distance and you will definitely see the markers here and where you should stop. Uh, if you go for, as I thought, if the anatomy pushes you to a different size and you need to replicate this, you still stick to the principles. You need, as much as possible, proper length on table. You need proper offset on table. So you check the repair of your flap, either you're doing posterior or anterior approach. You need to be sure that you restore the offset, so restore the soft tissue tension. You need to be sure that you restored the length, and you need to be sure that your implant is stable on stressing. So when you do telescoping, up down or telescoping in out, you need to be sure that your hip is stable. One main concept is never ever get a patient unstable on the table, because unstable on the table will never be stable after the operation. So you have to have your patient on table in a proper length, in a proper offset, in a proper stability. Otherwise, again, you're buying a failure. So don't say, oh, when I repair the soft tissue, stability will improve. This will never happen. You have to have your implant stable under stressing on the table. So never ever get your patient off table unless you're happy with the length, you're happy with the offset, you're happy with the stability. Happy doesn't mean ideal. It should be ideal, but if not ideal, never ever compromise neither the length, the offset, or the stability. Achieve as much as you can and never accept that your patient come off the table with unstable hip. Otherwise, it will never be stable. Decided the hip, we're choosing the component, we're choosing the way of pairing, with the pairing combination, we're choosing the way of fixation, we're choosing the head size, and now we are to the operation. We went into the operative theater. Couple of slides about the approach and the theater setup. A lot of approaches. You can use posterior, anterior, anterolateral, lateral, okay? Posterior, all the evidence is supporting. Every one of them has pros and cons. The more difficult and technically challenging is more stable, like the anterior approach. So the anterior approach need a very good learning curve, how to use the instrumentation, carries a risk of nerve injury and carries a risk of fracture of the femur. But on the other side, it is the most stable approach. So the hips done through anterior approach are more stable than others. Posterior approach is accused by instability or risk of instability because you get the short rotators off, but it's more versatile, it's easy to do, it doesn't need a learning curve. Everyone, the most junior registrar can do a posterior approach, gives you a very good view, you can see everything nicely, and I promise you with proper repair of the soft tissue in the posterior approach, you mitigating the risk of dislocation or risk of instability. Anterolateral approach, easy one, like you do your hemis all the time, every day. The only problem is you don't have a proper orientation of the acetabulum, and on the other side, because you violate the abductors, this patient comes very commonly with a limping gait. So if we go from these three approaches, lateral and anterolateral, there is no major difference, and you don't need to waste your time thinking about what's the difference between lateral and anterolateral because it needs a specific type of the patient. If we say the major three approaches used in the practice today is posterior approach, anterolateral approach, and anterior approach. In my hand, posterior approach is the best. With soft tissue repair, there is no problems, a lot of problems with instability. We cannot ignore that the evidence says that the anterior, then the anterolateral, and then the posterior regarding stability is the wrong or the right order. And posterior is the most unstable approach. But as I told you, if you do a proper soft tissue repair, it will be okay. So anterior approach needs a long learning curve, need to know how to use the instrumentation, need to be careful about the internervous plane and not to injure the, don't do a nerve injury and don't fracture the femur, but it gives you a very good stability. Posterior approach, easier, more versatile, better exposure. With soft tissue repair, yes, there is a higher risk of dislocation compared to anterior, but with soft tissue repair, you can mitigate this. Anterolateral approach, easier, safer than the posterior. There is no, you don't play with the sciatic, but it will end by your patient limping. And to be honest with you, from my humble experience, patients with posterior approach are much, much, much happier than anterolateral. So either anterior or posterior, anterolateral patients are the less happier. Factors in deciding what approach you will use for your hip depends on yourself. What's your training? What's your level of experience? What approach are you familiar with? Patient anatomy. So sometimes the patient obligate you to go for an approach like have a skin problem, have any concerns you worried about, have abnormal position of the sciatic. You open, you find the sciatic in front of you. You may opt to go for another approach. Surgical goals, what you try to achieve, what's your templating says, what will be your easy bit, what will be your difficult bit, and to a lesser extent, the patient preferences, especially nowadays, all the patient consult ChatGPT before they go for an operation. So, ChatGPT, what do you think the approach should be used for my hip? And he will follow ChatGPT more than his doctor. Your theater setup, we all know about. I will not waste a lot of time in this. So you know that you need the laminar flow. A lot of debate about the efficiency of the laminar flow in reducing the infection. You need a proper theater design, so proper theater zones. You need to be sure that you have your theater very clean, very low traffic, proper scrubbing, proper exhaust suits you wear. You need to be sure that sterilization is very, very good. Your trays and instrumentation trays are very, very sterile. You need to have a proper illumination, proper humidity, proper temperature of the theater. Positioning your patient, you have to do the positioning of patient, never leave it for the trainee. It's not about against the trainee, but this is the one who will operate has to position the patient because you will build all the steps, the next steps based on how did you position your patient. So you need to square your pelvis. You need to be sure that your pelvis is square. If you prefer to work on unsquare pelvis, you need to understand where is the unsquareness of the pelvis. Is your pelvis tilted anteriorly or tilted posteriorly? Because if it's tilted anteriorly, will give you a false impression that this leg is long. If it's tilted posteriorly, it give you a wrong impression that this limb is apparently short. And you can understand the inclination of the acetabulum only if you understand the position of the pelvis. Ideal to have your pelvis squared on the table, so everything is built on a squared pelvis. But some surgeon prefer to did like especially surgeon who is doing anterolateral, they aim to have the pelvis a bit tilted posteriorly. But it needs the surgeon himself to tell the pelvis in this way so he understand why he is where is the start point. So when he plan his surgery or steps inside the surgery, he understand where did he start from. If I position the patient and you operate it, I promise you, you will get everything wrong because you don't know how did I position my patient. So my advice for you is get your patient positioned by yourself if you will be operating, or by your trainee if your trainee will be operating. Proper padding, ensure that the patient is resting on the table, ensure that the patient is safe. Everything have a proper gel padding. There is no pressure points. Ensure that your supports are holding nicely and your pelvis is squared. Ensure that you have a full range of the head before the support stops you. Ensure everything is in place. Ensure that your patient is cleaned nicely. Some people advise now to go for 3 or 4 layers of venting. So venting in the anesthetic room, then getting the patient in, venting the patient again. This is a different practice. The idea about how much the preparation affects the infection rate is a big debate. But I can promise you at least the 3 layers is needed. So I do 1 layer in the anesthetic room, get the patient in, do another layer, then the final layer before we drape. Cell saver, keep it ready, especially if you have a complex primary or you have a revision case, because risk of bleeding is high. We're dealing with a hip. There is no option to have a tourniquet. You may encounter a big bleeder, especially if you're doing a posterior approach. And the lateral epiphyseal artery sometimes bleeds a lot. And if you have a bleeding, you have to have blood, cross-matched blood ready, and you have to have a cell saver machine ready. Thank you so much. So, but all your if you want to voice your questions, I'm more than happy to do that. If you want to put them in a chat, is again, I'm very happy to do that. So I can answer it for you. Hopefully, we stick to the time, and it was clear. And I try as much as possible to give you the debatable points and the points with flavor. And hopefully, this was useful. So if you have any question, just keep them in the chat and we'll answer them. The record will be available on the YouTube channel once we finish that. I'm keen to put in the YouTube channel as early as possible because I know the time is a bit late in different countries. We nearly 12 a.m. in Egypt. So I try to keep it on YouTube for who cannot attend. This course still have 3 lectures. Unfortunately, I couldn't stick to a certain time, but I'll try my best to finish this within the next couple of months, and will be completely available on YouTube channel. We offer a journal club every second Friday of the month, with a theme every month. So our next journal club is the second Friday of December, and it will be about hand papers. This journal club is absolutely free and it is CPD approved by the Royal College of Surgeons of Edinburgh. Ahmed has a question. Any method we can adjust the limb length without changing the offset? Uh, Theoretically, yes. Practically, no. So the answer is it is a triangular relation. So there is no way to change a limb of the triangle without changing the whole triangle. So changing a one limb of the triangle has to change the other limbs of the triangle. So theoretically, you're moving the stem up and down, you're changing the length in the templates. But actually, on the real life, every time you move it up, you shorten the offset, you move it down, you lengthen the offset. So it's a triangular relation. You cannot change one limb of the triangle without changing the other 2 limbs. So realistically, every time you're changing the leg length, you will change the offset. So even with the adjustment, so if I put like +4 adjustment for like on Exeter stem, Yes, it mainly increase the offset. It affects the lens very, very minimal, but it still affects the lens. So theoretically, yes, you can do. So with an adjustment, I can increase the offset. We're using like, if you're using like a 44 stem rather than a 37.5 stem, so you're increasing only the horizontal offset, but that's not true because the vertical offset changes as well, but to a very, very minimal degree. So practically, you feel like you changed the offset only, but actually you changed both, but without clinical implication of increasing the vertical offset. Even with modular prosthesis. Yeah. So with modular, so again, as I told you, with modular prosthesis, you can change one of them mainly, but this doesn't mean you're not changing the other. So it is a triangular relation. It's no way to change one limb of the triangle without changing the others. So, but as I told you, clinically, yes, you can because it changed. If I change like from 37.5 to 44, so we speak about 6.5 mm from the offset. This will be reflected as, it's not definitely a figure, but like less than a 1 mm change in the vertical offset. So with modular prosthesis, you can change the length or the offset, but keep in mind that the other ones is changing. That's why if you putting a hemiarthroplasty and your tissues are very in a lot of tension, you're reducing the offset or you're subsiding your or bearing your stem more in, you're changing the length and at the same time you're changing the offset. That's why when you get your stem more into the canal, this is should mainly reduce the length, but actually it reduces the length and the offset. That's why you feel that the offset or the tension is less. So answering your question, Ahmed, there is no way to change one of them without the other. But clinically, you think about you changing mainly the offset with minimal change of the lens or changing the lens with minimal change of the offset. So clinically, it shouldn't affect your operation. Any more question, guys? Good. Hopefully, there is no question because you got it completely, you understand it completely, and you got it completely easy and palatable. Uh, Next lecture will be about complications of post-total hip and total knee. We'll speak about in periprosthetic infection. We speak about periprosthetic fracture. We'll speak about wear. We speak about loosening. We speak about tendinosis. So hopefully it'll be a fruitful one as well. Thank you so much for who attended. Thanks for your time, and hopefully you got what you aim to get from it. Once we finish the Zoom, you will there will be a feedback from Zoom itself on the screen. So please don't ignore that. What your feedbacks for me to improve the sessions one after one. So know what did you like, what you didn't like. So work on what you did like and avoid what you didn't like or improve it. So once we finish the Zoom, the feedback will come on the screen. Thank you so much again, and have a good evening.